The brain, of course, is the organ that connects us to the world. It's what interprets the world for us. It's what programs the behaviors that then the world responds to in terms of seeing who we are and what we are and how to understand us. It connects the internal organs with the nervous system, our sense of self. So very much how we experience ourselves and other people are functions of the brain. Which is where brain injury, or anything that traumatizes the brain actually, becomes a problem. Because as you're looking at me, your mind is making certain interpretations of who this person is, what he's saying, what that means to you. But by and large, you're expecting me to act within a spectrum of behaviors and responses that resonate with yours. And if I began to act in ways that seem strange to you, just subtly strange, it wouldn't have to be egregious. I wouldn't have to be yelling at you or throwing things around, but just if all of a sudden I stopped looking at you and I started talking like this, you'd feel weird. Your internal organs would actually give you different messages than they're giving you now. If I didn't respond to what you communicated to me in a way that denoted my understanding of you and my getting of you, you would feel troubled. And you might feel some fear, or you might feel some distaste. You'd certainly want to move away from me. And you'd be saying to yourself, if you're the average person, you'd be saying to yourself, what's wrong with this person? Now, those words, what's wrong with this person, are the right words. But what's wrong with this person is not the right thing to say. Because implied in that, what's wrong with this person, just the question itself, what is wrong with this person, or more broadly speaking, what is happening with this person, what is making her, him, be, act, react the way they are, that's a legitimate question. In fact, it's an essential question. If we're going to understand each other, we really have to wonder, what is happening for that person right now? So what's wrong with this person is kind of a shorthand for that. But what's wrong with this person is not a question. It's a statement. And the statement is one of judgment, one of rejection. Now, if I was limping and had to use a cane or a crutch, if I was blind and had to use a guide dog, if I was impaired in a way that you could immediately recognize as being impaired, you would not be saying, what's wrong with this person? You might wonder, well, why is he limping? You know, what's happened to him? You might have some empathy for somebody with impaired vision. But there'd be no visceral negative reaction on your part. That's because you were very clear that they have an impairment in that particular organ or body part. When it comes to trauma, and I'm not talking about either developmental trauma or traumatic brain injury, you're still looking at a human being. There's no visible impairment that you can see, but the organ that's driving their behavior is impaired and making you feel very uncomfortable. Now, if it makes you uncomfortable and you look upon this person as somehow weird or strange and somebody that you want nothing to do with, which is how society responds to traumatized people, for the most part. It's how teachers respond to traumatized children. It's how the courts respond to traumatized people that come before them. It's we want less of you. We just want you out of the way. If we're that uncomfortable dealing with the traumatized person, imagine then for a moment what it's like to be inside the head of that traumatized person. Now, Dr. Bessel van der Kolk, who's a world trauma expert, and I had the pleasure of spending time with him in London just a couple of weeks ago. He's talking about trauma and when the brain gets traumatized. And he's talking about the brain changes. Now, he's not talking about traumatic brain injury here. He's not talking about the impact of trauma on the brain, emotional trauma. I'll be talking about TBI in this context. But he says, these changes in the brain explain why traumatized individuals become hypervigilant to threat at the expense of appropriately engaging in their day-to-day lives. They also help us understand why traumatized people are often keep repeating the same problems and have such trouble learning from experience. We now know that their behaviors are not the result of moral failings or signs of a lack of willpower or bad character. They are caused by the actual changes in the brain. Now that's doubly true of people with traumatic brain injury. And I don't know if any of you have dealt with people with dementia, a close relative, a parent perhaps, or a spouse, or even a child who's had traumatic brain injury. Even knowing that they have a specific impairment to their brain, even knowing that, in the case of dementia or in the case of TBI, how difficult it is for you to maintain a level of connection and compassion and presence and not become irritable and judgmental and reactive. Now, that is not a criticism of you or I who react that way. It speaks to the very essence of what human beings are, which is that we're related creatures, we're interrelated creatures. We think of ourselves as individuals, but individuality is, as important it is to recognize, it's also an illusion. In the sense that the very state of our bodies and our minds and our emotions, our physical posture, the state of our viscera, is very much dependent on attuned, synchronous, connected, reciprocal interaction with other people. And when the demented person, or the brain injured person, or the otherwise traumatized person cannot be reciprocal for us, cannot be attuned with us, we feel dysregulated. We feel uncomfortable. And then from that place of discomfort, we have to muster the strength and the vision and the insight and the compassion to help them. And then, again, imagine the sense of fear and panic and isolation and sheer rage at not being understood that the traumatized person then must experience day to day. So quite apart from the obvious impairments, the physical problems of balance and coordination and dizziness or whatever may happen after a traumatic brain injury, there's the whole shift in the sense of self and the sense of relatedness to others that happens, that is actually even more difficult to bear. I'm going to read you something a friend of mine sent to me. She has had both developmental trauma and being a high-performance competitive athlete, and also been in car accidents. She's also had traumatic brain injury. And she recently underwent experimental treatment called PONS, Portable Neuromodulation Stimulation, which attempts to stimulate the cranial nerves in the brainstem to alter neurological functioning in a positive way. And so she went through, I think, a 2-month program in Surrey. She was accepted for this study. And I'm going to tell you what she wrote here. She says, I've been in transition since late February, the end of the PONS study. Those 8 weeks in Surrey marked the best and worst biological medicine has to offer. It brought merciful, if challenging, relief in the confirmation, finally, she said, that repeated concussive blows to my head have caused damage. That it isn't a matter of mental illness or any kind of weakness within me. So just what she's saying here is that the acknowledgement that, yeah, that blow to your head or those repeated blows to your head really did change your brain, and that really did change you, and therefore you're not at fault. That relief, just knowing that itself, was a tremendous source of support to her. While post-traumatic symptoms remain, the daily challenges that compound and overlap such impacts are a complication of their own. The physio told me repeatedly, these are classic post-concussion symptoms, pointing out what I, in my conviction that they were psychological and thus surely somehow my fault, I failed to see. And then she writes, in matters of the brain, as much as the mind, standard medical practice simply hasn't caught up with science. She says, treatments for post-traumatic stress disorder largely ignore traumatic brain injury, she says. And treatments for TBI ignore post-traumatic stress disorder. Each condition magnifies and precipitates the other, yet the recommended guidelines for both don't just fail to correlate, they're sometimes directly counter one another. This leaves patients and physicians alike stuck in a relentless cycle of palliative care. No wonder I fall through the cracks in a medical chasm. And then she says, finally, what has been sustained in my understanding of traumatic brain injury is a little more self-compassion for the previously inexplicable symptoms, improved awareness of things that I help when I'm starting to slide, and a deep appreciation for meditation. So, this is a woman who's been through the medical system, diagnosed with probably 4 or 5 different conditions, medicated all over the place. And the system failed to recognize 2 essential components of causes of her behaviors and problems. One is that she was a deeply traumatized child. She suffered extraordinary trauma as a child, including sexual abuse and all kinds of things, which I'll talk about later. And she also suffered a number of brain injuries in accidents that she sustained as an athlete and also in car accidents. And the diagnoses took none of that into account. The diagnoses simply dealt with different manifestations of her trauma, but they never actually looked at the trauma itself. So personality disorder or bipolar disorder or whatever else diagnosis she got, looked at the effects of trauma without looking at the trauma itself that caused it. Now it follows that when you're looking at effects, you're not going to ever deal with the root of things. So to understand how to help people, we really have to understand the roots of their experience. Now, when I was looking at the research literature on the relationship between addiction or substance abuse and brain injury, my assumption would have been and was, that what I'm going to find is that people with brain injury will be more likely to be substance abusers post-injury. Because the areas of the brain that regulate behavior would have been damaged in the brain injury. Therefore, there'd be less impulse control, less regulation, more depression, more need to self-medicate. What's interesting is that the research doesn't actually support that. The research at best is ambivalent. And if anything, and in some studies, yeah, they do show that after brain injury, people do drink more and so on. Some studies show that, but overall, that's not what the research shows. So overall, what it seems to show is that rather than substance use being an effect of brain injury, much more often it's actually the cause of brain injury, or much more often it predates the brain injury. If it's not the direct cause, it predates the injury. So I think we need to talk about substance use as a major risk factor for traumatic brain injury, as a major risk factor, and I'll show you some of the statistics about that. And also, in some cases, as a possible outcome of brain injury. But in either case, there needs to be a dynamic, how should I say this, a dynamic flow between our understanding of brain injury on the one hand and addiction or substance use on the other, and not to put the two into different categories, but see how they actually interact. And that therefore, when we're dealing with such people, we have to specifically address, if they've had brain injury, we have to specifically affect the impact of brain injury, but not forgetting that the substance use that very often predated the injury was already also an impact of trauma. And here's where we'll have to talk a little bit about brain development. So when it comes to understanding substance use and addiction, our society takes a very simplistic perspective on it, which is best expressed by the man who now is the Attorney General of the United States. This is the guy who will be enforcing the law. And here's what he thinks about substance use. He said this a few months ago. His name is Jeff Sessions. We need to say, he says, as Nancy Reagan said, just say no. Don't do it. And our nation needs to say clearly once again that using drugs is bad. It will destroy your life. In the 80s and 90s, we saw campaigns stressing prevention. We can do this again. Educating people and telling them the terrible truth about drugs and addiction will result in better choices by more people. Now, how successful those so-called preventive strategies that he lauded so enthusiastically in the 18 and 90s, which mostly consisted of putting billboards on highways saying, just say no. How successful that was is shown by the fact that heroin use in the United States has gone up 5-fold in the last 10 years. And both countries, US and Canada, is facing this terrible overdose epidemic right now. I was in the downtown east side yesterday for a meeting, and the number of overdoses is just not dropping, despite the fact that there's actually more prevention services, and as was said in the introduction, there's more supervised injection sites being set up and so on. I can only wonder what the death rate would be if those services were not in place, because they save a lot of lives. But even with everything we've got in place right now, we're barely holding steady, and that steady is terrible. It's something like 4 overdoses a week in Vancouver. That's just in Vancouver, I think. I know that Kelowna has got a real problem as well. In the United States, they experience between 120 and 140 overdose deaths every month, which means to say that each month they have the equivalent of a 9/11 happening in that country. And as I often say, you think that if a situation was that dire, if the crisis was that great, we would just mobilize every medical and intellectual and social resource to deal with that epidemic. As we do, when it comes to something like the Ebola virus or the SARS virus or the Zika virus, that threatened very few people. Very few people died of SARS in Canada. But I don't know if you remember how much media attention there was, daily briefings by governments, mobilization of medical resources, for a problem that was, comparatively speaking, trivially small. And I'm not in any way diminishing the importance of dealing with such public health threats. I'm just saying, where's the proportion? And what does that have to do with? Well, it's got to do with something. There's got to be some reason why such levels of human suffering and mortality do not arouse the same level of concern and action on the part of a society. And what is that reason? I have to think, and I have no better explanation, and if you do, I'd like to hear it, that the reason goes back to what I was talking about in the beginning. That when we look at these people, instead of saying, what is wrong with them? We're saying, what is wrong with them? In other words, we see them as others. And we see them as willful. And we see them as the American Attorney General says, we see them as making a choice. Well, how accurate is that perspective? As I quoted from Bessel van der Kolk, it's not a moral failure. Trauma and its impacts are not a moral failure. It's not a choice. It's just what happens to the brain. So the reason I thought that looking at studies of addicted or brain injured people, I would see more addiction is because brain injury can damage the circuits that regulate, for example, incentive and motivation. As I'll be telling you in a minute, incentive and motivation are very important in driving substance use or any addiction. So if you injure those circuits, you expect more addiction, more substance use. Brain injury also can damage the cognitive capacity of the brain, the ability of the brain to actually read the situation accurately and to make decisions. Executive functioning is damaged. So that should drive addiction as well. The problem is, in trying to figure out which comes first, brain injury or addiction, well, epidemiologically, addiction comes first in most cases. But the problem is, although it's easy to understand how when you whack somebody in the head with a metal bar, or concuss them with a blow to the head, or whatever happens, it's easy to see why that would have a damaging effect on the brain. We're far, far, far behind the science to understand that conditions in childhood that interfere with healthy development can also impair the brain. And that means who are most prone to brain injury? It's young men, usually from late adolescence to early to mid-20s. These people generally lack impulse control, so they tend to do things thoughtlessly. They'll get into situations that can possibly endanger them. They'll get into a fight in a bar, despite the danger. They have poor decision-making capacity, poor impulse regulation, and so on. Which are exactly the brain functions that childhood trauma can impair. In other words, what I'm saying is that for the most part, not exclusively, but for the most part, traumatic brain injury happens to people already traumatized. Now, if you look at brain development, that's not even controversial. And the problem with the material I'm presenting to you now is that A, it's completely established brain science, number one. Number two, it's completely unknown to most care providers. So that it's quite astonishing when you think about it, that physicians are not given a single lecture on brain development. How does the human brain actually develop? Nor, equally astonishingly, nor are teachers. So, kid goes to school, it's got this brain, and the teacher has no training whatsoever in understanding how the child's brain functions, how it developed, and how to affect it positively to nurture healthy growth. And what kind of interactions with adults will either promote or inhibit healthy brain development. So I'll read you just a few paragraphs, 2 paragraphs actually, from an article published in the journal Pediatrics, which is the official journal of the American Pediatric Academy. You couldn't get more prestigious than that. And the article comes from the Harvard Center on the Developing Child, published 5 years ago now. And here's what they say. The architecture of the brain is constructed through an ongoing process that begins before birth, continues into adulthood, and establishes either a sturdy or a fragile foundation for all the health, learning, and behavior that follow. So pretty much everything that you see in terms of human behavior is actually the impact of brain development, which makes sense. Because the brain is the organ that generates behavior. Now, tomorrow in Vancouver, I'll be speaking to a conference on prisoners. I was reading yesterday in the New York Times, this young man, Dylan Roof, who killed all these black people at this church. I forget which southern state or town it was in, but you remember the tragedy last year. He represented himself in court, and his statements were, typically racist, dark hatred. Or these people needed to be wiped out to protect the white race. What is clear from the article in the New York Times yesterday, though, is that he should never have been allowed to defend himself. He's got severe psychiatric problems. In other words, his brain is impaired. And his very act was a sign of a traumatized brain. In which case, not only why is he allowed to defend himself, why is he even a criminal case? And I'm not talking about in any way validating or approving or accepting the outrageous statements that he made. I'm talking about who's generating that insanity. Well, somebody who's developmentally impaired. And I have no doubt whatsoever, if I were to look at his childhood, we would see that he just didn't have a chance to develop a healthy brain in the conditions under which he was raised. So again, the architecture of the brain is constructed through an ongoing process that begins before birth, continues into adulthood, and establishes either a sturdy or a fragile foundation for all the health, learning, and behavior that follow. They didn't say some, they said all the health, learning, and behavior. Notice something else here too. They say this process begins before birth, which already means that the experiences of the pregnant mother have an impact on the child, a child's future, including the child's future mental health. So for example, if you look at adopted kids, they have adopted people in general, they have double the risk of suicide. They have several times the risk of ADHD. They have increased risk of mental health problems of all kinds. Well, why? Well, one theory, if you're a genetic fundamentalist, would argue that this is because it's genetically deficient people who have to give up their babies for adoption. So naturally they have kids who are born impaired. That's one theory. The other theory, much more in line with reality, is that any woman who's going to have to give up a baby is by definition stressed. She's stressed not only because she'll have to give up the child, she's stressed also because if she wasn't stressed, she wouldn't have to give up the baby. So she's a single mom, a poor mom, an addicted mom, a teenage mom, an abused mom. So for 9 months, the hormones of stress are going through to the baby. And those hormones of stress actually have a negative impact on brain development. And then comes the separation from the birth mother, which is a trauma, which the adopted person cannot recall because the part of the brain that you recall with isn't developed yet, doesn't develop till a year and a half or later. But the emotional memory of being separated and therefore rejected by the world, which is mother. I was inside the world, my mother was the world. And if she then gives me to somebody else and I don't ever experience her heartbeat and her voice again, I'm being rejected. And that sense of rejection then is ingrained in that person. And then that person doesn't act quite like a normal child. He or she will not be as responsive, as attuned, as reciprocal, as clued in as a child who's really welcomed into a nurturing, healthy environment. And then how will the world treat him or her? Like I said before. And then the sense of rejection is reinforced daily, in daily interactions with other children, and with caregivers, and with teachers, later on with corrections officers and police personnel, and so on and so on. You got this vortex of trauma from which the kid never escapes into adulthood. And then they say in the next paragraph, the interactions of genes and experiences literally shapes the circuitry of the developing brain and is critically influenced by the mutual responsiveness of adult-child relationships, particularly in the early childhood years. So it's not genes that determine the brain, it's the interaction of genes and experiences, because it's experiences that actually turn genes on and off. A gene can be there. You can get 2 kids born with the same gene. You might have, for example, a gene to do with serotonin transport. Serotonin being an important brain chemical. And you might have a variation in that gene in 2 different individuals. And one person becomes addicted because he's a bit more sensitive and susceptible. The other doesn't, but they have the same gene. And if you actually look at what happened was that the person who does become addicted, they had childhood trauma. The person who did not become addicted with the same gene was in a nurturing home. So in the one case, the gene is turned off, and the other gene, in the other case, is activated by the environment. So genes don't determine, for the most part, they are actually activated by the environment, particularly when it comes to the complex set of human behaviors. There's no gene that determines any human behavior. So it's the interaction of genes and experiences that literally shapes the circuitry of the developing brain, and is critically influenced by the mutual responsiveness of adult-child relationships, particularly in the early childhood years. So actually, the most important determining factor that shapes the circuitry, the physiology, the connectivity of the human brain is the quality of parent-child interactions. And if the parents are emotionally attuned and clued in and calm themselves, then a child's brain will develop the capacity to regulate itself, and a child will develop impulse control and insight and empathy and so on. But what if the parents are abusive, which often they may be, not because they mean to be, but because that's just how they were programmed, trauma being multi-generational. But never mind that. What if the parents aren't even abusive? What if they're just depressed? And a depressed parent cannot attune to a child. What the child needs, the infant needs, is a playful, joyful parent to interact with. You know, the kind of silly game playing that you see moms and little babies do? It's just totally automatic and instinctive. But a mother who's depressed, she can't do that. That already is having an impact on the child's brain development. So in one study I know, they looked at the electroencephalograms, the EEGs of 6-month-old infants whose mothers were depressed, comparing them to the EEGs of infants whose mothers were not depressed, and you could tell from the EEG of the infant whose mother was depressed and whose wasn't. That's how interactive we are as human beings. But this is really important from the perspective of treatment. And I'm anticipating maybe the conclusion of my talk, but really it doesn't matter. When we're dealing with people who are troubled, either because of early trauma, or because of brain injury, or, as in most cases, a combination of both, it's absolutely essential that whoever works with them really works on this attunement business, on this being in tune with, actually getting, so that we're not responding to behaviors, we're not reacting to behaviors, we're actually reacting to the emotional state of the person who generates the behavior. So, if I was talking with you, and all of a sudden you yelled at me, which a traumatized person might do, I could respond in two ways. I could, who the hell are you to talk to me that way? You know, get out of my office. Or I could say, gee, you must feel a lot of anger right now. My capacity to respond in the second way, and speaking of myself, believe me, I can swing both ways depending on what mood I'm in on a given day. But my capacity to respond in that second way depends very much on what? It depends on my own capacity to regulate myself. And the problem for these people is that for the most part, when they were growing up, they were never with people who had the capacity to regulate themselves. Hence, they never developed self-regulation. So the implications of just these two little paragraphs in understanding of any mental health disorder, addiction, human behavior, brain development, and dealing with traumatized people are actually immense. Now let me say a few more words about addiction. I'll give you a definition of an addiction. This is a party trick that I do. Addiction is any, manifested in any behavior that a person finds pleasure, relief in, and therefore craves, but it has negative consequences in the long term, and the person can't give it up despite the negative consequences. So, craving, pleasure, relief, negative consequence, inability to give it up. I said any behavior. I didn't say drugs. I didn't say substances. I said any behavior. Naturally, it could be substances, nicotine, cigarettes, caffeine, cocaine, crystal meth, opiates. Could be sex, could be food, could be internet, could be work, could be gambling, shopping, anything really. So, I'm just going to ask you a question. According to this definition now that I've just given you of what an addiction is, how many of you would acknowledge that at some time or another in your life you had an addictive pattern? Just raise your hand. Okay, well, so, and just look around. Who doesn't, you know? I'm going to ask you the next question. And then the reason I'm doing this is because we need to explode the myths that surround addiction. Now, if you're looking at the terrible outcomes that we're confronted with, and the sheer failure of the treatment system to redeem a lot of people, at some point you have to ask, well, is it that we're not doing enough? Or is it that what we're doing is based on a wrong understanding? At some point you'd have to at least ask that second question. At least you'd have to think about it, entertain it. And just keep doing the same thing, over and over and over again. And even throwing more resources into the same programs may not get you too far if those programs are based on false assumptions. Now, the assumptions about addiction, substance use in our society, substance abuse, are twofold. One I've already dealt with, that it's a choice that people make. Well, we can just forget about that one. Unless you're the American Attorney General, in which case you're going to make the laws tougher, keep people in jail longer, which is exactly what they're going to do now. Welcome back to the future. The other assumption is that we're dealing with diseases. So that, there's the depression, which is a brain disease, and there's anxiety, which is a brain disease, schizophrenia, which is a brain disease, there's an addiction, which is a brain disease. And of course you can make a case that, yeah, these conditions behave like diseases. They're chronic, they have relapses, they have remissions. Sometimes they respond quite dramatically to the appropriate medication. They tend to run in families. A lot of the markers of disease are there. Does that make them into diseases? It does not. That's why I'm going to ask you the next question. When you think about your own addictive pattern, and I don't care what it was, and I'm not going to ask you what it was, but whatever it was to, whenever it was in your life, and however long, I'm not going to ask you any specific questions, but ask some of you just to raise your hand and then tell me, what did you like about the addiction? What did it do for you in the short term? Okay? Anybody? Just raise your hand. Second, yeah?
Take away pain and relief.
It took away pain. Emotional pain? Okay, it relieved the emotional pain. Thank you, yeah?
It was calming.
It calmed you down. Thank you, yeah?
Utopia. Utopia. It gave me a sense of belonging, relief.
Oh, okay, belonging and relief. Okay, great. Let's just take those three things. I won't even take any more. So, calming, in other words, self-regulation, a sense of connection, belonging, and pain relief. Now, anything wrong with any of that? Who wants to be in pain? Naturally, people move away from pain. Who doesn't want to be calm? Who does not want to belong? In other words, the addiction wasn't your problem. The addiction was your attempt to solve a problem. Your problem was of emotional pain. Your problem was of lacking a sense of belonging. Your problem was an internal agitation, a lack of peace. To call the addiction a disease is to ignore the fact the addiction actually was your answer to the problem. It may not have been an adequate answer, it may have been a self-defeating answer, but it was an answer that was the best answer you could find at that time. And the real question is, what happened to you that you did not develop a sense of internal calm, or that when you lost that calm, you had no internal self-regulation, or you didn't know what to do in the world to calm yourself down, short of an addiction? What happened that there's 7 billion human beings on the earth, and you didn't belong? What happened? I'm not criticizing, I'm just saying something must have happened. You're wired for connection, as I was saying, we're relational creatures, and all of a sudden, 700 billion people in the world, and I don't belong. Something must have happened. And of course, something must have happened to give you emotional pain of such degree that you had to run away from it. And that you lack the capacity to deal with. So the addiction is not a primary problem. The addiction is a secondary problem. It's a life problem. And if we wish to understand why people are addicted, we have to look at their lives, and not at their genes, and not just at their brains either. Well, because the brain itself is shaped by your life. This is the whole point. That the brain itself is shaped by your experiences. Now, in the downtown east side, in 12 years of work, I did not have a single female patient who had not been sexually abused as a child. Not one. And all the men I spoke to had been sometimes sexually abused and sometimes in other ways, but all of them were deeply traumatized. And if that were only my particular observation, it might be interesting, but it wouldn't be particularly persuasive. But it's also what the large-scale study shows. So, I mean, study after study, large population studies show that the more adversity you experience as a child, the more the risk of addiction. And how many of you, just raise your hand if you're familiar with the ACE studies, just raise your hand. I'm always surprised, and don't take this as a personal critique. I'm systemically surprised, I shouldn't be at this point anymore, that here we are in a room of caregivers, professionals, dedicated, well-trained, skillful people. And yet some of the basic information necessary for your work has been denied to you by your education and your training. I mean, that just shows you what I'm talking about. So look, tonight, go to the internet and download the ACE studies, Adverse Childhood Experiences Studies. Download the ACE score and use them with your clients. It'll tell you everything you need to know about them. An ACE is physical or sexual or emotional abuse, a parent dying, a parent being jailed, a parent being mentally ill, violence in the family. Did I say a parent being addicted? A divorce or severe neglect, okay? For each of these, the risk of addiction goes up exponentially. That means if, according to the research literature, which is the case, the vast majority of people in some studies, pre-traumatic brain injury, were already into heavy substance abuse, then that means that they all had high ACE scores. And you need to know that about them. Because then you're realizing that you're not just dealing with the effects of a brain injury, you're also dealing with the effects of pre-existent trauma that already affected the brain. Because as I read you from that Harvard article, the brain is affected by the environment and the development of its circuitry. So what I'm saying is that these ACE studies, which have been done in California, in Finland, most recently in Alberta, and they always show the same results. The more childhood adversity, greater the risk of substance abuse. Not only the greater risk of substance abuse, greater the risk of mental health issues, ADHD, addiction, depression, anxiety, and of course of brain injury. So on one level, we have to understand addiction as somebody's attempt to make the world a little bit more benign, to make the world a little bit more livable, to make the experience of life a little bit less harsh, a little bit more pleasant. And what I'm really talking about is whether it's anxiety and hypervigilance, whether it's not a sense of lack of belonging, these are all manifestations of emotional pain. So the first question in addiction, this is my mantra, is never why the addiction, but why the pain. And if you understand people's pain, you have to look at their lives. Not at their genes and not at their choices, but what actually happened. Something happened. So that's on one level. On another level, I will just quote you. I was in London for a few weeks, came back last week, and went to the National Gallery, where there's a lot of beautiful art on the walls, including a magnificent painting by Van Gogh, the transcendent Dutch painter. And he's the famously, he's the one that cut off his own ear at some point, and I believe it ended up committing suicide. It's about this book, but to do with him, and he was a drinker. And clearly he had bipolar disorder. So, just to quote you, as the year wore on and his work rate went up, his consumption of alcohol increased again. This was partly a reaction to the stresses and anxiety of work itself, but also a way of quieting his mental turmoil. When worried about disastrous possibilities, he threw himself into painting. He worked in any case so as not to suffer too much mentally. In other words, work itself was an escape. And he added, if the storm within gets too loud, I take a glass too much to stun myself. It was his wildly fluctuating moods that seemed to be at the root of the trouble. In Paris, he had suffered so severely that they made him fear for the future. At times, he put them down to bad wine. Possibly it was actually too much wine. Vincent complained repeatedly that his blood had not circulated, which he cannot have meant literally. Metaphorically, he seemed to be talking about the terrible lethargy of depression. When he was in that state, alcohol was enlivening. Conversely, when he was agitated, it soothed him. But in neither case was it doing him any good. Now again, a lot of the young men who get TBI actually were heavy drinkers. And in one study, they looked at the outcome after the head injury, comparing previous history of alcohol consumption and the violence that actually caused the head injury. They found out the previous history of alcoholism had a more dire effect on the outcome after the brain injury than the cause of the brain injury, whether it was violent or not. Which would make sense. Because if I'm walking down the street and randomly somebody tries to hold me up and they hit me over the head with a crowbar, but I have no history of drinking, then you can assume that probably I didn't have trauma before. But if I'm a drinker and I go into a bar and I get injured in that environment, the fact that I was a drinker means that I was already traumatized. And that drinking was designed to soothe my highs and lows, or to make me feel better about myself, or to escape from my pain. And of course, my brain was already impaired in some ways prior to the injury. Now, just a few final words. As always, of course, and the reason I can't stay with you much longer after my talk is because the last time I was in Kelowna, I talked on addictions, and I was then confronted in a friendly way by two native women from the Splatson Reserve. And they said, well, we have a terrible problem in our communities. A lot of violence and addiction and suicides and the whole thing. What can you do? I said, well, and then I remembered that I was coming here for this talk. And I said, well, if you can make it work, why don't I come to your community and just give a talk and talk about stuff and see what little difference that might make. So that's what I'll be doing. So they said, yeah, and so that's what's going to happen. But the reason I mention that is simply because, as always, whatever we're talking about, whether it's addiction or violence or trauma, our indigenous population is overrepresented. So that in this talk on prisoners I'll be giving tomorrow, I'll have to note that while First Nations people make up I think about 4 or 5% of the Canadian population, they make up 30% of the jail population in the country. See what we do? We traumatize people. They act out their trauma through substance use or some other means, and then what we do is we re-traumatize them by putting them into these terrible facilities. And that's what we call a civilized society. So it's not surprising, therefore, that when it comes to brain injury also, Indigenous Canadians are overrepresented. It says here 50% of homeless individuals live with brain injury, and the vast majority, 77%, were injured prior to becoming homeless. I think she's talking about natives here. 82% of the prison population experienced traumatic brain injury. So when you actually look at, again, amongst natives, again look at what happens is, if you look at who's in prison are people whose brains had no chance to develop properly in the first place because all the conditions were lacking for that. And I don't have to go into the historical reasons for that. Except there's one story I don't get tired of telling, just because I think it needs to be told. I received a package in the mail yesterday from a native woman from Seychelles, who's in her 50s and who's been addicted since she was 9 years old. And this package, she went to a rehab program again. She hasn't actually been using, she just wanted to go through the recovery program again. So she went to this program where they had to write down all the dark stuff that they'd done in their lives, how they hurt people, not what happened to them, but what they did to others. How they hurt people and felt envious and jealous and projected negative energy and all this stuff. So she sent me this thick document. They're supposed to burn it. As you know, I put it out of myself and I'm going to burn it. I'm done with the past. For some reason, she didn't want to do that. And so she said, can I send it to you? Because I know her, and the reason I know her is because I've done some work with her. And her story was, so she sent it to me, so I got this. I'll read through it, I think she wants me to. But her story was, and if you've heard it before, pardon me, but when she was 4 years old, she was taken to residential school here in British Columbia. This is in the 1960s, we're not talking ancient history here. And this 4-year-old native kid at the residential school made the mistake of speaking her native language, which was a no-no. And so the teachers stuck a pin in her tongue. And this 4-year-old sister, for a whole hour, not able to put her tongue back in her mouth, because if she did, she would cut her lips. And that's before the sexual abuse started. So she was an alcoholic by she was 9 years old. And these are the people who are in jail. Now, what does that all mean? It all means that, first of all, there's nothing more challenging than working with people who are mentally challenged themselves and who are or who have traumatized brains. Because as I said in the very beginning, it pushes all the wrong buttons inside us. Our needs for being understood, respected, connected with are just frustrated at every turn. Our need that our work should be effective is so that we can feel better about ourselves is frustrated because these people tend to relapse. And then of course we get tense and then we project that tension onto them. This is challenging, very important, very sacred work. It's just about the most difficult thing you can do. You know, again, if somebody breaks an arm and your job is just to fix that fracture, or if you're the nurse tending to that person post-injury, that's okay because you're attuned, you're aligned, you know, you're on the same wavelength. Now the functions of the midfrontal cortex, the gray matter right here in the front, which Bessel van der Kolk calls the watchtower of the brain, which is what stands over us and kind of regulates us, are regulating the body, attuned communication with other people, emotional balance, response flexibility. In other words, our responses aren't programmed, automatic, reflexive reactions. Like you show a dog a bone, they start to salivate, you know. That's just a reaction. Insight, empathy, modulation of fear, intuition. These are all functions of the midfrontal cortex. These are just the things that are going to be lacking in our clients. A, because of early trauma, and or because of traumatic brain injury. Which means that our midfrontal cortex has to work really well to work with these people. And if we can bring our own best self to the task, our presence, our intuition, our empathy, our insight, our own modulation of our own fear, our own capacity to be flexible in our responses, to be emotionally balanced, to be attuned in our communication with them, well, that then will give an opportunity for their brains to acquire those capacities. I'm not talking about what technique you're using, what skill you have. Many of you have skills and techniques that I don't, and maybe I don't even know about. I'm just talking about the underlying approach that must be there for anything that we bring to bear to actually work. I think what's important is to recognize that, and you've all seen this, that the human brain does have the capacity for positive change. It has the capacity for positive change even after direct physical brain injury. We know people with strokes who recover function. It's slow work. And if we can deal with the underlying emotional aspects and the traumatic imprints from childhood, then the physical limitations become just that, physical limitations. But they don't have to underline the sense of self. They don't have to interfere with the person's capacity to interact with others. They don't have to erode our sense of belonging. And so ultimately, it is always, always, always a matter of relationship. And the quality of that relationship will do much more than just make a person feel better in the long run. It'll do what, had they had better relationships in the first place, they would have developed these capacities already. It'll help them, these capacities of empathy and attunement and self-regulation. Maybe even a way that they never had before. Thanks very much. Thank you. So, and that leaves us about 25 minutes for questions or so, I think.
Yep.
Or 20, okay, so if you have questions, just raise your hand and the mic will, I think, come to you.
You worked very intimately with this population, particularly the addictions population. And as a medical practitioner, you have, I think, a lot of insight into our medical system, which is very under-resourced to help these people. If you could just make one change in that system, what do you think would be the most important change to make?
Oh, yeah, I'll jump on that right away. It's not just that it's under-resourced, it's that, as I said before, even if we put more resources into the same system, it would still be inadequate. Because the fundamental understanding of addiction and of mental health in general, I didn't have a chance to talk to you about other mental health conditions, is just really poor. So that if I could change anything, I would train physicians and teachers and kindergarten workers and prospective legal personnel and prospective law enforcement personnel and first responders. I would train them all in trauma and in recognizing how trauma shows up and how to deal with it. That's the one. Now that would not cost extra money, but it would call for a different orientation. Okay, any other questions?
Most depressions come from not having people to talk to,
Okay.
and learning how to talk to people and coming together is more beneficial than what's happening now. That's all I gotta say.
Which is also what the research shows. In other words, community-based programs and peer interaction programs are actually amongst the most effective practices in dealing with TBI. So you're 100% right. The research is with you. Okay? Any other questions or comments?
My children were raised with Steiner education in the schools, and I experienced there seemed to be recognition of, as you said, personalities and traumas, and I saw children that were medicated on ADD and then who later adapted to, came to that education and within 4 months were off the education. I don't know if you can comment on Rudolf Steiner's findings.
Yeah, so the dominant model in psychiatry these days is what's called biological psychiatry. In other words, whenever anything goes wrong in terms of human behavior or mental functioning, we think there's a disease there, and we think that disease is based on some biological problem in the brain. If that is the case, how do we fix it? By changing the biology of the brain. And how do you change the biology of the brain? Well, you give medications that alter brain functioning. So in the case of ADHD, you give Ritalin or Dexedrine or Adderall, some stimulant, and so on. Now, it may be that there's a biological substrate to mental dysfunction. Clearly, look, I've taken medication for ADHD myself. It made an immediate difference. I've taken antidepressants. And that made a difference too, almost immediately as well. I don't take anything anymore, but this was years ago. So clearly, by changing the biology of my brain, there was some beneficial impact. However, what the biological perspective ignores is that the brain itself a product. The brain is not the cause. The brain is both a cause and a product of life experience. So that if you're only dealing on the biological stratum, you're ignoring the interconnectedness of how the brain functions with life experience. Therefore, another way to change brain functioning is to alter that person's life experience. Now, when it comes to the developing brain of a child, if a child's got ADHD and you give them ADHD medication, which is happening, as you know, in increasing numbers these days, that may result in a temporary improvement in the child's functioning in the short term, but you've done nothing for the brain development. Because the medications don't promote brain development. For all we know, some of them might even interfere with it, especially when it comes to some of the heavy-duty medications that they use. But if we understood this interaction between life experience and the very function of the brain, then what we would do is when we have troubled kids or ADHD kids or any kind of kids, we would say, well, what life experience is, that means what experience is in the home, what experience is in the playground, what experiences in the schools would promote healthy brain development, and what experiences would undermine them. We would still be dealing with the biology of the brain, but we're dealing with the biology of the brain from the perspective of long-term development, not of short-term symptom control. So if you're going to use medications with a kid, well, if you're totally driven to do it, and by the way, I question that there should ever be the first-line treatment with any kid. But let's say you decide at some point you have to bring them in just to get some respite. That's just the beginning.